Hello everybody, welcome to our last short topic-specific webinar of 2020. So today we'll be covering febrile, allergic and hypertensive reactions, and you'll be having presentations from our working expert group in this area. The first speaker will be Dr. Janet Birchall, who's Medical Director for the Welsh Blood Service. She's been part of this group for quite some time now. We've got Dr. Jayne Peters, who's a Consultant Haematologist at Manchester University NHS Foundation Trust and works at NHS Blood and Transplant also. And we've got Dr. Catherine Booth, who is our newest member of our FAHR family, and she is a Consultant Haematologist at Barts Health and works at NHS Blood and Transplant also. So for the duration of this webinar, you're going to be kept on mute, just to help any background noise. If you've got any questions, please pop them in the Q&A box, and we won't be able to monitor the comments box. So any questions in the Q&A box, we'll have a 40-minute presentation, and that'll be followed by a 20-minute Q&A at the end of it. So I think that's our main housekeeping. I think I will now hand over to Janet to start today's presentation. So thank you.
Hello everybody. Can you hear me? Yeah, you can't answer, but I'll presume the answer is yes.
Your sounds good, Janet.
Thank you. I'm going to start the presentation by taking you through the definition of febrile, allergic and hypertensive reactions, and then show you the data that's been reported over the last 7 years. I've divided this into what hasn't changed over this time period, what has changed, and what we have very recently discovered. So let's start with the definitions, which are isolated febrile reactions are those which aren't associated with other reaction types, such as hemolytic, transfusion-related acute lung injury, transfusion-transmitted infection, etc. Allergic, which classically presents with any of the following: skin rash or itching, angioedema, airway constriction causing respiratory compromise, or circulatory disturbance with hypotension. Hypertensive reactions are similar to febrile in that they must be isolated and not associated with other reaction types. Next slide, please. SHOT has adopted the International Haemovigilance Network British Society for Haematology classification as shown in the table. Mild reactions are not SHOT reportable. So a febrile reaction with only a temperature but less than 39, or a rise in temperature of less than 2, an allergic reaction with only a rash, and a hypertensive reaction with a drop in systolic pressure of less than 30 are excluded. Next slide. So what hasn't changed? The difficulty differentiating between symptoms, signs associated with the patient's underlying condition and a possible transfusion reaction. This is compounded for us by insufficient information provided in some cases submitted. I'm now going to show you data regarding overall numbers, reactions by component type, and the management of reactions. This slide shows cases reported per blood component over the last 7 years. Issues over time are shown in the last quarter of each of the graphs on the right-hand side. Overall, the number of components issued has reduced, but reactions haven't clearly shown the same downward trend. This is likely because more cases are recognised and reported rather than because the incidence of reactions has increased. This slide shows the age distribution, gender, urgency of transfusion, timing of transfusion, and location reported in 2019. As you can see, most patients are adults, there's an equal gender split, and the vast majority of reactions occur on wards. This slide shows the type of reaction, age, gender, urgency of transfusion and location reported over the last 7 years, and there's no obvious trend. I'm surprised that there aren't more transfusions and therefore reactions in outpatient daycare settings rather than on wards in the last few years, given the pressure on beds, but the data doesn't show this. Reactions by component type are also stable. This is the 2019 data, but consistent with previous years, showing most reactions to red cells are febrile, but most reactions to plasma components, i.e. platelets and plasma, are allergic. I've chosen red on the chart to indicate febrile reactions. I've chosen blue and grey to represent pure moderate and pure severe allergic reactions, to remind people that allergic reaction types are not associated with fever. If they are, the reaction would be classified as a mixed allergic febrile reaction. Although most pure febrile reactions are treated with paracetamol, a significant number are treated with an antihistamine plus or minus a steroid, which is hard to understand. This is also reflected in future management where this is stated and potentially detrimental to the patient. Conversely, the management of most allergic reactions seems to be more appropriate with antihistamine steroid and, when severe, adrenaline. So what has changed? The name of this shock category. In autumn 2017, I was horrified by more than one haematology registrar in an FRC Path Viva defining an acute transfusion reaction as only isolated febrile, allergic or hypertensive reactions. After this, I proposed a title change from acute transfusion reactions to febrile, allergic and hypertensive reactions, which better describes the content. Platelet additive solution was introduced to replace plasma in platelet pools in 2015 in UK blood services. Apheresis platelets have remained suspended in plasma. Look at the chart on the right. Since then, there's been a clear reduction in the incidence of allergic reactions associated with pooled platelets, and significantly less than associated with apheresis platelets. This is in keeping with published studies. The lack of an effective platelet additive solution on febrile type reactions is likely because these are caused by the accumulation of cytokines post-storage and not directly related to the plasma. Continuation of allergic reactions to pooled platelets is, at least in part, also likely to be caused by release of substances from the platelets themselves. What have we just discovered? This. When we recorded the number of cases which we, as shot reviewers, recategorized, such as from allergic to febrile, and according to the symptoms and signs reported, we reclassified nearly 40% of all reactions. I'm now going to hand you over to Jayne to take you through some cases, how we classify, and some key messages over this time period.
Thank you very much, Janet. So, as Janet just said, I'm going to go through a series now of illustrative cases, and these cases are going to look and reinforce some of the messages we've just heard. So first and foremost, that febrile reactions should be treated with paracetamol, but yet in almost half of the cases, we're seeing the addition of antihistamine and steroid. The other thing which I'm going to emphasise here is about the classification. So as Janet just said, 40% of the cases which are submitted to the FAHR chapter, we as an expert group have to reclassify. So it's just going through what we're looking for, what the criteria is, and how to submit these cases to the right groups. Okay, so for you, those in the audience that aren't reporters, the way in which the information is submitted to us is we get a short description of the case, what actually happened. We then ask the reporter to specify what symptoms the patient had, and sometimes we get some additional information within those symptoms. We ask them to specify what management the patient had, and we also ask them to classify what type of reaction. So I've summarised and much shortened versions of some of these cases. So the first case is a 72-year-old gentleman with a diagnosis of myelodysplastic syndrome, and he was transfused red cells. During the transfusion, his temperature rose from 37 to above 39 degrees, and it was an association with rigors and with nausea. So to summarise the symptoms, we had a greater than 2-degree rise in terms of his fever. He had chills, vomiting, tachycardia. The management seems completely reasonable. He had paracetamol for his fever. He had antibiotics. He may be neutropenic. He's got MDS. And he had some antiemetics as well for the nausea and vomiting. And this was rightly classified as a febrile transfusion reaction. Next click, please. And one more. And the learning point here is this is a case where things have been done really well. So for febrile reactions alone, treat with paracetamol. There's no need to add antihistamines or steroids to this case. Can I have the next case, please? So the reason why I showed the good example is because case 2 is almost absolutely identical, but was managed and classified in a completely different way. So case 2 is of a 70-year-old female that's got a diagnosis of non-Hodgkin lymphoma. She was also transfused red cells for symptomatic anemia. During the transfusion of her 3rd unit, she complained of feeling unwell, felt sickly, and her temperature rose to 39.4. She was cold, she shivered, and she vomited. So again, symptoms, greater than 2 degrees rise. She's got chills, she's got shivering, and she vomited. But the management's very different here. So she had paracetamol, as was the last case, but she also had the addition of an antihistamine and the steroid hydrocortisone. And dantrotron and saline were given in the context of her vomiting and nausea. Now, hydrocortisone may not be beneficial for this patient, as Janet's just described. She described it as detrimental for patients that are immunocompromised already. And obviously this patient has a background of non-Hodgkin lymphoma. This was classified as an allergic reaction. Next click, please. But when we look at all the symptoms together, there's no allergic symptoms to report. So the allergic symptoms, as Janet described, what we're looking for are those of itch, those with rash, angioedema, bronchospasm, wheeze, and certainly nothing like that stands out in this case. This is a very straightforward febrile transfusion reaction that should have been managed with paracetamol alone, and antihistamines unlikely to do anything, and hydrocortisone may actually hinder the patient. And the classification here should have been febrile transfusion reaction. And again, just to reinforce, if it's a febrile transfusion reaction alone, treat with paracetamol. Next case, please. So just a sort of a little side diversion, I'm just going to talk through some of the differential diagnoses of febrile transfusion reactions. So one of the things that we ask the reporters to do, other than go through the symptoms and go through what they think the category of reaction is also to report the imputability. And what this is how certain can we be that this reaction is secondary to the component and not something else? And it's very rare that we're absolutely certain that this is due to the component. So the first differential diagnosis is that the fever may be related to the underlying diagnosis of that patient. For example, we get lots of leukemia, lymphoma, myeloma, MDS patients, and they're prone to having fevers because they're neutropenic. It may be disease themselves which makes them have the fever. And therefore it's really difficult sometimes to know if it's the blood component or if it's the disease itself which is causing the fever. My key point here is that febrile transfusion reactions can happen with patients with those underlying diagnoses. So just because they've got leukemia or lymphoma doesn't mean that they can't also have a febrile transfusion reaction. So sometimes we get reporters put imputabilities of 0, which means it's excluded, when it may be potential or possible that the fever could be related to a transfusion reaction. There are cases, such if you had a lymphoma patient which spiked a fever every night at 9 o'clock of 39 degrees, and they just so happened to be having blood at the time, I would agree that's much more likely to be consistent with the disease rather than the actual transfusion. So it's all about the context in which it's in. The next is infection and sepsis. So again, if a patient's admitted and they've already got signs of pneumonia, already got a bacteremia, and they've had ongoing spiking throughout the day, then it may be that the transfusion which they receive is unlikely to have caused that, but sometimes it may be a possibility. The other thing which I was going to emphasise is if you have a transfusion reaction which is febrile and you do a full septic screen after it to do your full investigation, including chest X-ray, blood cultures, etc., sometimes you find evidence of new infection, and that could be, again, be a pneumonia, a UTI, a bacteremia, for example. And if you have these symptoms, it'd be worth reporting those back to SHOT just so we can update whether, so if you had a bacteremia, I'll talk a little bit more about transfusion transmitted infections in a moment, but it would be consistent with that diagnosis of a bacteremia rather than the blood component itself. If it's nothing to do with the blood and it's nothing to do with the actual patient, then especially for our haematology patients, we have to consider whether it's the line. So peripheral, sort of PICC lines, central lines, Hickman lines. If sometimes we get reports of sort of isolated infections in those lines, and therefore we can quite confidently exclude that it's not related to the transfusion, but the actual line itself and the infection which is localized there. Transfusion transmitted infections we spoke about, well not we, was spoken about in a SHOT's webinar a few weeks ago now. And transfusion transmitted infections, as it sounds, means the transmission of an infection. In this context, it usually would be bacterial infection, which may manifest as a febrile reaction in the patient. If you have concern that your patient has a significant fever and the fever is out keeping with what you would, what you were expecting, please call the NHSBT consultant on call. They'll go through all the details with you in terms of, the clinical details and the specifics of what happened during that reaction. And they decide whether we recall that unit and whether we recall those associated units as well. What we do with that unit is send it to Colindale, to our National Bacteriology Laboratory, which we abbreviate to NBL, and they do blood cultures on the blood unit and can conclude whether there's any evidence of bacterial transmission during that transfusion or not. It'd be worth also doing your peripheral or your central line cultures as well. So if anything was grown, we can compare both of them to see if there's any evidence that there is any evidence that the transfusion transmitted that infection or not. Transfusion transmitted infections in the context of bacteria are very rare. They're incredibly rare with red cells because of the sort of leukodepletion process, because of the storage temperature, etc. But they're a little bit more common with platelets. Even so, the risk of having bacterial transmission of a clinically significant organism from platelets is incredibly small. The final topic which I wanted to touch on is hemolytic transfusion reactions. So sometimes we have cases which are submitted to us where a patient has a significant fever, but when the blood is sent back to the laboratory and investigations are undertaken, we find that there's a new DCT positive when they're doing past the serological investigation. We may see an increase in the DCT or the DAT positivity. And when they assess the patient's blood tests, we may see signs of hemolysis. And those would be, so an increase in your bilirubin, an increase in your LDH. We can see a reduction in your haptoglobins, the presence of hemoglobin, etc. And together, this would paint a picture of a hemolytic transfusion reaction. It may be that your site do sort of the antibody investigation on site and identify what antibody it is, or they may send it off to RCI to investigate what antibody it is. But if you're in that situation, then it should be reported as a hemolytic transfusion reaction and not a febrile transfusion reaction. It has its own category. So the learning point, so first and foremost, is that febrile reactions may occur regardless of what the underlying diagnosis is. So don't just rule it out if a patient has, say, leukemia or lymphoma. And sometimes we have reporters put an imputability of 0. So they're saying, you know, there's no way this is related. And the reasons which they give is because they found nothing on the laboratory serological tests or on the microbiology tests. And the opposite is true. We don't expect you to find anything on these tests. And that is the febrile reactions we want you to report. Next slide, please. We'll go back to our cases. So the next case is a 39-year-old gentleman with a diagnosis of AML, and he was transfused a dose of platelets. 15 minutes post-transfusion, his temperature increased by greater than 2 degrees, and he had rigors. Other symptoms included a rash and an itch. So again, we've got fever greater than 2-degree rise. We've got rigors, but we've also got some allergic symptoms here as well, an itch and a rash. This gentleman was treated with antihistamine and hydrocortisone, and it was classified as an allergic reaction. Next click, please. So if we look at all those symptoms together, so this demonstrates that the patient had both febrile and allergic reaction together. And in the context of them both together, there is a specific category called mixed reaction, as you can imagine. And therefore, we reclassified this from allergic to mixed. It'd be worth saying as well that he had really quite minor symptoms in terms of his allergy symptoms, an itch and a rash, and maybe again hydrocortisone would be potentially detrimental to this patient in terms of making them more prone to infection in view of their immunocompromised state, rather than helping the transfusion reaction. Okay. The final case I'm going to take you through is a 69-year-old male with MDS who was transfused a dose of pooled platelets, and this was prior to a Hickman line insertion. From memory, his platelet count was sort of between 10 or 20. He informed the unit he was on that he has an allergy to platelets, and he received both antihistamine and hydrocortisone before they started the transfusion. Midway through the transfusion, he developed a rash and an itch, chest pain, and dropped his blood pressure. The symptoms summarised, so rash, itch, hypotension, but it wasn't ever sort of stated exactly what that blood pressure drop was, and chest pain, which may be part of the transfusion reaction or may be secondary to the degree of hypotension. We don't know, it's not stated. The management was adrenaline and oxygen. He was treated for an almost anaphylaxis reaction, which may seem appropriate if we knew what the degree of hypotension was. When the reporters have gone to classify this, they've reported this as a hypotension reaction and not an allergic reaction. So next click, please. Okay, so as Janet said, a hypotensive reaction is in isolation. So if it's associated with febrile symptoms, it's a febrile reaction. If it's associated with allergic symptoms, it's an allergic reaction. And this certainly has signs of allergy symptoms in the history of somebody with significant allergic symptoms. So therefore, we reclassified this as an allergic reaction. The other point to make as well is that if you're reporting a hypotensive reaction, that we need to know what the starting and what the end blood pressure were, just so we can make sure it fulfills the criteria as Janet described. The final point here is just that hypotensive reactions may occur in association with other things. So, for example, in the context of intraoperative cell salvage, you can certainly see hypotensive reactions, but this will be reported to the cell salvage chapter and not to ourselves as a hypotensive febrile allergic or hypotensive reaction. Next slide, please. So I'm going to finish my part here, just going through some key short messages. So firstly, it's fundamental for all staff in transfusion to understand a basic mechanism of reaction so that immediate treatment and the future management is rational rather than traditional. So you saw in some of those cases that it didn't matter what the patient had in terms of their symptoms, they were all going to get treated the same way in terms of a sort of a transfusion reaction cocktail, paracetamol, antihistamine and some steroid. That's what we're trying to discourage and what we need to try and educate those on the ward to base it on the symptoms and target those symptoms. The other thing, as a key message, as Janet pointed out, is that we've now feedback if we reclassify your reaction. And what we hope is that this allows you to sort of challenge, it helps you to learn, and it helps you to grow in terms of your ability and confidence as reporters to improve the understanding and management of reactions if we tell you, actually, this is an allergic, for example. Next slide, please. I've said this a few times already, but for febrile reactions, and if they're in isolation, it should be management with paracetamol alone. For allergic reactions, your first line should be antihistamine. And obviously, in the context of severe allergic reactions or anaphylaxis, adrenaline as per national guidance. Steroids have no immediate effect. They're not going to help that patient there and then, but they may help things several hours down the line. For some patients, that's not going to be an issue. Steroids, as I've mentioned, may immunosuppress the patient who may already be immunocompromised due to the underlying condition and therefore increase risk of infection rather than actually helping the transfusion reaction. Next slide, please. So this is taken directly from the SHOT chapter, and it's a table where you can refer to, which will go through what the treatment should be and what the preventative treatment should be. So if we focus on the preventative treatment, for febrile reactions, if your patient is known to have a febrile reaction, then the recommendation is that paracetamol is given 60 minutes or so before the transfusion starts. For an allergic reaction, again, we don't want this blanket pre-medication with antihistamine and steroids. What we recommend instead is if you've had a previous reaction which is allergic and association with apheresis platelets, that you try pooled platelets in platelet additive solution or PAS, as Janet described. If you've tried that and the reaction continues, try a pre-transfusion antihistamine. If the reaction continues despite that, speak to one of the NHSBT consultants and go through the clinical history and the reaction, the severity, etc. And it may be that this patient is suitable for consideration of wash components, whether that's red cells or platelets. If it's a plasma component in which the patient's reacting to, the recommendation would be to try a pool component, such as a solvent detergent treated plasma. Next slide. And I'm going to end on our lovely infographic, which again is in the SHOT chapter for 2019. It reinforces our key messages. So do not use steroids indiscriminately. With every transfusion reaction, you may be doing harm. For febrile reactions alone, give paracetamol. And for allergic reactions, give an antihistamine as first line. And don't forget, obviously, if it's a severe transfusion reaction, adrenaline as per the anaphylaxis protocol. I'm going to hand over to Kath Booth, who's going to go through 1 or 2 final slides and the future of FAHR.
Brilliant, thank you, Jane. So it falls to me just to draw together some conclusions before our question and answer session. So first of all, that over 1/3 of cases that were reported to FAHR in 2019 were reclassified. And hopefully, having attended today, you'll feel more confident in getting that right. And then we saw nearly half of those isolated febrile reactions were given the antihistamine and steroid cocktail instead of just an antipyretic. So hopefully events like this and the SHOT resources can help you to differentiate between those types of reactions so that they can be managed more appropriately. Also, we know it's challenging to differentiate types of reaction and the cause of the reaction. But remember, pure allergic reactions aren't associated with fever. They can be more than just a rash and itching though. So they can get some unusual GI symptoms, particularly abdominal pain, diarrhea, nausea, vomiting, and that could be a sign of an allergy. And it's only those patients with allergic features who warrant treatment with an antihistamine, and a steroid only if it's a more severe reaction. And as we've all said, patients who are unwell in hospital receiving transfusions may have an awful lot of other things going on related to their acute illness or their long-term clinical condition. And it can be hard to separate whether a reaction is because of that or the blood component and exactly what class of reaction you're witnessing. Next slide, thank you. So how can we help? How can we help you to get this right? Well, first of all, we're grateful for all of you for attending, and you're now the ambassadors. So please go back to your workplaces and take our key messages and the messages from the report back to your clinical teams and your transfusion teams and see if you can get these embedded in your trust policies. That's particularly with regarding the clinical management of reactions. And for those of you who are reporters, please use that really handy table. You can have that stuck on your wall of your office where you're reporting, and that'll help you to better classify the reactions and also distinguish those mild reactions that we, obviously they're important, but we don't need to hear about those. Next slide. The other great resource we have is the new SHOT app. And this is something that, because it'd be on your phone, it's there readily available for you to use at the bedside to help you recognize the reaction and then determine the appropriate management. Next slide. And you can get that by downloading, either by using these QR codes or if you search for SHOT UK in the Apple App Store or the Google Play Store. And that's available to download now. So after you finish listening today, that's your next job. Now, as you heard at the start, I'm the newest member of the FAHR team. And so I found myself questioning, we're talking about reactions here that are largely not preventable and unpredictable. Sort of idiosyncratic reactions. So what's the point? What's the role of SHOT in collecting this data? You know, how can we use this information to make transfusion safer, which is what's at the heart of SHOT? Well, there's a few questions where data can help us. So first of all, is there something that we can do with our component design and manufacture to help cause fewer reactions. We've heard first that since we've been using platelets in additive solution, that we've got fewer allergic reactions. Can we do more for our apheresis platelets to reduce the plasma content? And that is something that the component development team are working on. And it will be important for SHOT to continue collecting data if we do make those changes to assess the impact. The other point that's very interesting is Janet had mentioned that often febrile reactions are due to build-up of cytokines in our blood components over time. And so one of the pieces of data we're trying to assess is whether you're more likely to get reactions for older units. And if that's confirmed, maybe we should be making recommendations that certain patient groups receive fresher units. So that's a useful piece of research we're doing at the moment. And having mentioned that certain patients might be more susceptible, is there a way that we can risk stratify before a transfusion? So another common cause of febrile reactions is non-red cell antibodies. So things like HLA antibodies, HNA antibodies. And you're more likely to have formed those antibodies if you're multiply transfused or if you're a female who's been pregnant. So does our data tell us that those patient groups are more at risk of reaction, in which case you might monitor them more closely, be more ready to give a premedication if they've had more than one reaction? And is it predominantly those sick patients in hospital with other infections or particular conditions that are getting reactions? All of this might help identify who's going to be at risk. And then hopefully we've emphasised today the need to manage these reactions appropriately. So we've spoken a bit about the good resources, and I know you'll all go away with that emblazoned on your memories, but how do we maintain that good practice that you're going to start from today? I wonder if it'd be helpful to have some sort of benchmarking, so for your trust to be able to see what percentage you managed appropriately compared to the rest of the country. And you may be aware that SHOT are interested in starting to collect data about areas of good practice, not just where things went wrong. And is this one area where this could be useful? So how did other trusts make a durable change in management? How have they got over this inbuilt tendency to give that cocktail of paracetamol, steroids and Piriton to absolutely everybody? So awesome food for thought for the future. Next slide, thank you. So before we draw to a close for the question and answer session, I just want to say to thank the whole SHOT team for all their hard work, for providing us the data and for supporting this webinar today. For all my fellow working expert group members and the SHOT steering group, the MHRA Haemovigilance team, and then all of you who we may moan about your reporting, but it's absolutely vital for us to be able to provide this data, and the UK Forum for funding. I'd like then to open up to the whole panel to take any questions from all of you listening.
Vicky, before we start with questions, can I clarify one point, please? So it was popped up in the chat, and I know you've told people to put them into the Q&A box, but just to clarify, when I'm talking about for febrile reactions, give paracetamol alone, obviously if you've got an immunocompromised patient and you're concerned this may be signs of infection or sepsis, always treat them with antibiotics and do what you usually would be doing anyway. My emphasis was on not giving antihistamine and not giving steroid, not treating them. So it's important just to make that differentiation. And of course, with our haematology patients, they're super special. And if they do have a fever, we do want to act really quite quickly if there's signs of infection.
Lovely.
Thanks, Jayne. That's really good to clarify. So we've got lots of questions coming through. Thank you for submitting those. So I'll kick off with the first one, if that's okay. So we had a question: do you think the SABTO change to not require apheresis platelets for those born after 1996 will impact the number of FAHR reactions? Anybody like to take that? Janet, should I direct that one to you?
I think that's exactly what SHOT's set up to work out. So if everybody submits data for their reactions and the type of platelet used this year, we'll have the answer by July.
Yeah, so it's kind of wait and see, isn't it? And then the pattern should emerge. That's great. Okay, Vicky, do you want to field one of the next questions?
Yes, no problem. So thank you for everybody for engaging in the questions, and thank you for voting as well, because that makes it really easy for us to understand what are the important questions as well. So the next most popular question is, what is the mechanism behind hypertensive reactions? Quite a interesting question there. Has anybody got an answer for that one?
I can respond to that one, Vicky. So it's thought to be related to the presence and the metabolism of a naturally occurring peptide in your body called bradykinin. And what bradykinin does is it causes vasodilation. So it makes your veins expand, which lowers your blood pressure. We see hypotensive reactions quite commonly in the context of patients that are taking ACE inhibitors. And the relevance here is that ACE inhibitors, that ACE is, again, a naturally occurring enzyme in your body, and it breaks down the bradykinin. But if you're inhibiting ACE, then your bradykinin can remain in the system, it can accumulate, and therefore you're much more likely to get a hypotensive reaction. We did previously see that before 1998, when we introduced the pre-storage leukodepletion, which we have now, those that were having post-storage leukodepletion and bedside leukodepletion were seeing an increase in incidence of hypotensive reactions at that for those patients. And the mechanism again is related to bradykinin, because the negatively charged filter was releasing more bradykinin through a separate mechanism related to factor 12, which I won't go into. And because of the increase in bradykinin, we're seeing these patients have hypotensive reactions. We've seen a lot less hypotensive reactions now we've introduced the pre-storage leukodepletion since 1998. And we saw last year 3 cases which we confirmed to be hypotensive, which represents approximately 1% of the data.
Brilliant, thank you, Jane. We've got another question here, and I think this is an interesting one that came up on our CPATH as well last week. So what are SHOT's view on the use of cold storage platelets, and do these offer any advantages in reducing the likelihood of potential transfusion reactions?
I think that's a really interesting point, and again one where probably only time will tell. They've only been used in relatively small numbers of patients in clinical trial settings, so not enough to have for us to have collected data about reactions. You can see advantages and disadvantages. So one of the potential advantages is that you might be able to extend the shelf life of platelets, and that there may be less transfusion transmitted bacterial infection. That's very hard to measure when we've got scarcely any at all, as it is. But at the same time, if older platelets are more likely to cause reactions because of build-up of cytokines and other chemicals released from the platelets, you might actually find that that longer shelf life results in more reactions. So who knows, but certainly, again, the SHOT will have an important role in collecting that data if that is a product that gets rolled out.
And I think that emphasizes the importance of continued reporting as well. With any changes in the component, it is actually important to recognize the trend, and so that we can actually match it to what changes have happened.
Brilliant, thank you, Catherine and Shruti. Vicky?
Lovely, thank you for that. I think one of the ones that popped up, I think Jane's just answered slightly, saying how common are hypertensive reactions. So I think that was fairly rare.
No.
I think Jane's answered that one off, so I'll leave that on if that's okay. But the next the next question is, how do we inform the reporters if we reclassify incidents?
Do you want me to do that?
Lovely.
Yeah, go
thank
ahead,
you.
Janet.
For the first time in 2019, we included a column when we classify cases to identify if we've changed the classification. As I've said, we change the classification if the SABRE report identifies one reaction type, but the signs and symptoms would suggest otherwise. And then a member of the SHOT team reports that back to whoever submitted the case. I've actually never been challenged about that. So I don't know whether you're all just think, oh, all right then. But we're very happy to have that dialogue if you don't understand why we've done it.
Definitely, yeah. Thank you, Janet. So the next question we've got is, if a 1 degree Celsius increase in temperature occurs during transfusion, should the transfusion be continued?
I would love to answer that because this is one of my pet hates.
Thank you.
It really is about the clinical assessment of the patient and how they are. So it makes me desperately sad that many transfusions are wasted because someone has a very mild rise in temperature when otherwise they are absolutely fine, and someone as a knee-jerk reaction has taken down the transfusion, thrown it away before even a medical review. And I know some centres have had a lot of success in really training and empowering the nurses who are managing transfusion to be able to manage that decision on their own much better. So the key thing is, so how is the patient? Do they have other symptoms? What are their observations like? Follow your your guidelines, which often will help you divide your reactions into mild, moderate, severe. And if your patient is absolutely fine with no other symptoms and you've repeated your bedside checks, you know it's the right component, the right patient, the right time, then there's no reason that you shouldn't go ahead with the transfusion. If they're symptomatic, you can give an antipyretic, give paracetamol, and just the key thing is monitor them more closely and don't throw away the blood.
Yeah, it's that time to just take stock and reassess the patient carefully, isn't it? Definitely. Thank you very much. Over to you, Vicky.
Lovely, thank you very much, and thank you for all these questions. I don't know if we'll get through them all today, but we'll keep hold of them, and we will hopefully get the answers to you. So next question is about HLA matched platelets. Do these have a role in preventing allergic reactions, or is that something else going on there?
I can take this one potentially. So HLA matched platelets, obviously given for patients that have platelet refractoriness or patients which are known to have significant antibodies, which may mean they don't increment to normal platelets. HLA platelets, matched platelets, are apheresis platelets. So when Janet described earlier about the difference between pooled and apheresis, so apheresis platelets will be given in the plasma of the donor. So it's almost full plasma in which those platelets are suspended in, and those that are pooled have a significant proportion of that plasma removed and replaced with the patient platelet additive solution, the PAS, and therefore they're much more likely to not cause sort of an allergic reaction because of the PAS. And the relationship here is we feel that some of the allergic reactions are due to substances found in the plasma itself. So HLA apheresis platelets, which are suspended in plasma, are unlikely to cause a reduction in your allergic reaction. But hopefully the opposite's true, and as we said, time will tell, that the increased use now of pooled platelets may see that reduction in allergic manifestations.
Thank you, Jane. Okay, so moving on to the next question. To the non-clinically trained, can you elaborate on the harm caused by inappropriate steroid use? This may help in those circumstances when needing to challenge a clinical decision. I would like to take that. Do you want to take that one again, Jane? Or because I know it's a point you were very keen to stress.
Yeah, so it's well recognised that steroids can sort of suppress the immune system. That's what we sometimes give them for, to dampen down immune responses. And if you have a patient, not even in the context of sort of a hematological malignancy, but if you're on regular sort of steroids, maybe in the context of other sort of autoimmune conditions, you're much more likely to be immunocompromised and susceptible to infection because of the result of those steroids in which the patient's taking. What we're trying to discourage is the repetitive sort of pulses of large doses of steroids without the clinical indication, because you know, fair enough, if your patient's almost got, going back to the cases, the patient had a really severe reaction, almost like an anaphylactic type reaction, you could justify that that patient would require steroids, and we've been through some of the preventative measures as well. But what we're trying to discourage is the persistence of a blanket approach and this idea of pre-medication involving some hydrocortisone as well. So these, like I said, these patients, unfortunately, it may not help whatsoever, but may actually immunosuppress them further.
Lovely. Thank you for that, Jayne. I think probably got time for 2 more now. So this is getting very exciting now. I know we've gone over this a little bit in the presentation, but when would you advise paracetamol as pre-medication? Is it only in patients with history of febrile reactions, or how much history?
Do you want me to do this?
Lovely.
Yeah.
Thank you.
Well, in my hospital, when they did the 15-minute temperature check, if the patient temperature was starting to rise, they'd give paracetamol then as a prevention. And then you don't get to the situation whereby you've got a significant rise and you start to worry about it. I did an audit when I was a baby doctor looking at how many patients who were having a transfusion as an outpatient actually had a temperature rise of 1 degree, and it was a huge number. I'd submitted it as an abstract, but the BBTS decided they weren't going to accept it.
You've got your moment now, Janet.
Yeah. But there was an enormous number, and actually because the patients were all really well, nobody actually noticed. It's very common. If you've got somebody with as Jayne said, if you get somebody with a recurrent febrile episode, and they often they can occur towards the end or even after the transfusion's finished, and you have to try and time your paracetamol so that it's active at the time the patient has the history of a reaction. So that's not necessarily pre-transfusion.
Yeah, it's patient dependent. Thank you. So probably got time for 1, possibly 2 more. Should we consider whether patients are taking ACE inhibitors when having a transfusion as a risk factor for developing hypotensive reactions, so monitor more vigilantly?
What I'd say to that, so as I explained, it's a really small proportion of patients that have a true hypotensive reaction, but there is an association with ACE inhibitors. So if a patient is already established on an ACE inhibitor and doesn't have any problems, I wouldn't be trying to create other issues. But if they did react, it would be a time to maybe liaise with the GP and see if there's a different type of antihypertensive that the patient could go on to if they've not had any, so if they did present with a hypotensive reaction in that context.
Okay, lovely. Is there a very short one, Vicky?
Maybe just this one of how would you treat a hypertensive reaction? What do you do then?
Yes, the first thing to do, as with all transfusion reactions, is to stop the transfusion and keep the unit aside and maintain their sort of central access with fluids, etc., and ask for a medical review. It should be quite quickly turned around and managed in the appropriate hands. It may mean that these patients need further care and even critical care with the use of vasopressors to restore their blood pressure sufficiently. So it can be really quite scary for those involved looking after the patient at the time, but just be reassured that usually it's quite quickly reversible with the right treatment, but unfortunately sometimes that treatment is the use of vasopressors.
If I can just add one quick comment, is actually importance of patient education as well, and also consenting and providing that information to the patients as part of the pre-transfusion discussions that you would be having. While all of these are acute, we also need to be aware there may be some delayed reactions to transfusion. So especially in patients having day-case transfusions, it is important for them to be able to recognize any red flags so that they seek appropriate medical help promptly. And please be aware of your local transfusion policies, because while we have given the examples as pertinent to, like Jayne was talking about NHSBT, you would have in your respective devolved countries as well the respective blood service, as well as the local red cell immunology labs that would be involved in your local transfusion laboratories. So please become familiar with your local policies, protocols, and approach the right team.
That's great. Thank you very much. So that's us out of time for more questions, unfortunately. We will kind of endeavour to answer any that weren't answered live retrospectively and get those back to you. So thank you again to all the panellists, and especially to Jayne and Janet and Catherine. It was a brilliant talk, and I think it really showed their experience of SHOT and FAHR, sort of past, present and future, really. So it was a really interesting talk, and I think the illustrative cases are always of great interest to us all as well. While we're beginning to just wrap up, we've just got about 4 minutes left, and we're going to display a live poll, which we always do at the end of our webinars, just with some really simple questions, and we'd be really grateful if you could fill those in just to give us some evaluation and direction. So the first one is just to what extent did you find this session useful? 1 is not very, and 5 is very useful. Just the country you're viewing from, please. And also, if you could just tell us if you're viewing the webinars as a single viewer, or whether there's a few of you looking at one device, sort of socially distanced within an office. That will really guide us to know our participation as well. And also staff group, and you can select more than one answer there if you've got a few different groups of staff viewing together. So thank you all for taking the time to attend today. And for your input and efforts really throughout the year to assure effective haemovigilance, whatever your role is in it. The holiday period can be a time where often hospitals see perhaps a more skeleton staff and a reduction in, elective procedures. However, we can occasionally see spikes in errors, so your vigilance and reporting is extremely important to us to keep up over any holiday periods. And if you do have any reporting queries, we're still here to field those over the festive period, so you can contact the SHOT office. It's been the very last webinar of 2020. We hope you've enjoyed them and above all learnt from them. And I think, as Catherine alluded to and made a really good point, that you're all in a great position to take that learning forward and hopefully spread and embed these safety messages in your clinical areas as well. We'll be back with more webinars next year, and don't forget to check our resources in the meantime. But that leaves me really to wish everybody a happy and most of all safe festive period. I think we all deserve some sort of finisher's medal for 2020, don't we? Because it's been one hell of a year. And while 2021 may continue to have lots of uncertainties, we do hope that the new year brings you lots of hope and prosperity. So thank you, and we'll see you all next year. Thank you very much.
Thank you. Just to clarify for everybody, recording of the webinar will be available on our website in the next few days, and then you can use that to cascade the learning even further. But echo everything Emma says, thank you to everybody.
Yeah. Thank you. Bye.
Thank you all. Bye.